Welcome friends. Let's complete our topic, pregnancy-induced hypertension. So till now we have seen the symptoms, the definition, what are the complications, and we all agree that antihypertensives are the basis of our treatment because they help us to delay the complications and thus prolong the pregnancy for a longer time so that we can attain, the fetus can attain maturity. But whenever we are giving this antihypertensive or whenever we are selecting this antihypertensive, we have to be cautious. We should give those drugs which will not cause sudden hypotension. There should not be overzealous correction of hypertension because the other important factor is the fetus. And we want enough blood to reach the fetus so that fetal growth will not get hampered. So now see this, there is an MCQ that which antihypertensive is not safe during pregnancy, and the options given are clonidine, hydralazine, metoprolol, methyldopa and losartan. So here the answer is losartan. It's not to be given in pregnancy. Now let's see why. Groups of antihypertensives which are the safe ones in pregnancy. Beta blockers, they are very safe. Cardioselective, or the most commonly used is labetalol. Labetalol is the drug of choice, I would say, as an antihypertensive because it decreases the blood pressure, it delays the complications as well as it maintains the feto-maternal or materno-fetal circulation. It doesn't, the chances of developing IUGR is much lesser with labetalol, and it also gives a good hypertension control. Methyldopa, again very popularly in use, and many people will vouch for this drug. It is very commonly used in practice. Clonidine, calcium channel blockers, nifedipine or dihydropyridines. Nifedipine is again a good drug, but it causes certain symptoms like maybe headache or palpitation, or there can be sudden hypotension. It's never to be given sublingually in hypertensive ladies. Oral, it does have good effect. It has effect on uterine contractions as well. It causes uterine relaxation. That's why we also use this drug as a tocolytic. So some say that it may interfere with the process in labor, but all in one, it's a good antihypertensive. Hydralazine, used as IV for urgent or in emergency crisis. Prazosin and other alpha blockers, and cardioselective beta blockers like atenolol, they are the ones who are safe in pregnancy. Please remember this chart because there are at least 20 MCQs on this, that this would be the drug of choice or these are the antihypertensives which are given except, and there would be a name like ACE inhibitor or enalapril or losartan or something of that sort. Someone which is contraindicated will be put there. So you have to remember which are the important antihypertensives. Now let's go to the list. These are the antihypertensives which are to be avoided in pregnancy. Diuretics have no role, they are not to be given. ACE inhibitors, they hamper the renal function, and that's why in fetus they will cause anuria and oligohydramnios. So ACE inhibitors like enalapril, captopril, they are not to be given in pregnancy. Non-selective beta blockers like propranolol, sodium hydroxide, losartan, reserpine, these are the ones which we should be avoiding during pregnancy. Now coming to the other important part of PIH, that is eclampsia. Now we all know that preeclampsia, along with if there is either convulsion or coma, then we call it as eclampsia. Lightning, sudden lightning, that's the Latin word that means that. Flash of lightning means what happens? The patient who is on antihypertensives or she's having PIH, preeclampsia symptoms, suddenly she develops convulsions. These convulsions are because of vasospasm, cerebral anoxia, the focus that releases that causes cerebral irritation, and there is convulsion. The other thing, there may be cerebral edema or cerebral dysarrhythmias which will lead to convulsions. And with each convulsion, prognosis worsens and morbidity of that patient goes on increasing. It is leaving that ischemic focus in the brain with every convulsion. That's why we want to have minimum convulsions and we want to deliver or terminate the pregnancy so as to stop the continuous process. Eclampsia, dramatic representation, patient giving history that she either had some warning symptoms in the form of headache, nausea, vomiting, or sudden giddiness, and then she doesn't know what has happened. Then we have to ask the relatives. Relatives tell us that she suddenly threw a convulsion. Maybe she had a fall or whatever, she just sat down. She may get injured sometimes. There is uprolling of eyeballs, tonic and convulsive phase, tonic and conic phase, frothing. So these are the classical presentation of eclampsia. And then when the patient is brought into the hospital, she is usually unconscious, semi-conscious, or in that phase in between two convulsions, whether she is not really very responsive. In such cases, we need to manage the patient. In management, we have seen that eclampsia is to be managed. Immediately, we don't want her to have any stimulus again. Otherwise, she will throw second convulsion. She's likely to throw another convulsion immediately. So we shift her to a dark room, minimum stimuli. Then we want to do a quick examination. We want to know what is her blood pressure. We want to confirm that this is eclampsia only. We will put a catheter fast, take urine sample, confirm that urine protein is present, start IV, give her fluids, not much in quantity but maintain IV line. Then we have to give her some anticonvulsant immediately because she may land up in another convulsion which will be increasing its morbidity, her morbidity. Then we want to do quick per abdomen examination for our second patient which is there, and we want to know that how is the fetus inside, whether live, whether dead, whether there is any other complication, what's the maturity. And then we all know that the termination is the only curative thing for her. So we want to know what is her PV status, that is the cervical status, and that will decide whether we want to induce it with oxytocin or prostaglandin. The bishop says poor, less, but we all know that once eclampsia, termination should be done. Now let's see in detail the management. General management, as I said, fluids overload should be avoided. It should not exceed more than 2 liters in 24 hours. Antibiotics to prevent infection. But what is the main treatment is anticonvulsant. Anticonvulsant to be given so that she doesn't convulse. Which are the drugs of choice in pregnancy? Magnesium sulfate is the answer. There should not be any doubt. MgSO4 is the drug of choice as an anticonvulsant in eclampsia. There are many regimes. The most famous one is Pritchard's regime. Again, this slide, many questions. Pritchard's regime is what? We'll see in detail. Other regimes, Zuspan and Sibai, Lytic cocktail. Krishna Menon, Indian person, has added pethidine, and this was made very famous by them at that particular time. And phenytoin. Even diazepam can be added to complete the list. But drug of choice remains as magnesium sulfate because good anticonvulsant, it gives good control over convulsions as well as the fetal depression is less. So MCQs can be asked. Best drug for seizure control. Options: phenobarbital, diazepam, phenytoin, valproate and MgSO4. You know the answer. Least effect on neonate is seen with eclampsia who's given magnesium sulfate, Lytic cocktail, diazepam, phenobarbital. You know the answer. Both the answers are MgSO4. Now let's see what is Pritchard's regime. Loading dose. It's a cardiotoxic drug, so we have to be very careful. It comes in two concentration, 20% and 50%. 20% and 50%. The dilutions which we use to give IV dose is 20%. 4 grams. This is the only drug which comes in grams. So say 4 grams. We have to give IV diluted over 3 to 5 minutes, keeping a hand on her pulse so that we know whether she is landing up in bradycardia. Sudden bradycardia is known. So that is why dilute the drug enough, give it very slowly over 3 to 5 minutes and with her hand on her pulse. Followed by 5 grams of 50% solution because there intramuscularly we are going to give. So we want higher concentration of the drug and lesser quantity. So 50%, 5 gram in each buttock. That means 14 gram we have given stat. Then the maintenance dose is 5 gram of 50% solution intramuscularly 4-hourly in alternate buttocks. And this is to be continued 24 hours after the last convulsion or delivery, whichever is the latest, so that she will not convulse again. So this whole thing is called as Pritchard's regime. This was formed for the non-Indian females. For Indian female who have little less weight, so we may modify the dose of the maintenance doses. Either we can give it, the 5-gram dose is given either 6 hourly, or sometimes the dose is given less. So every institute has its modification. But when Pritchard's regime is asked, you have to tell these doses only. Now magnesium is known cardiotoxic drug. It has its own toxicity. But it's best anticonvulsant, so we are giving it. But that needs to monitor the toxicity of magnesium. What are the things which we should be seeing before giving next dose of magnesium? 3 things. The deep tendon reflexes, that is knee jerk. Then protein to see the urinary output. Catheter is already there, so we want urinary output at least 30 cc per hour, and the respiratory rate. So these 3 things we should be monitoring when we are giving magnesium. The levels which we want are, the therapeutic levels are 4 to 7 milliequivalents per liter of magnesium. That's our aim. But if the drug is not getting metabolized, or if there is toxicity, the first sign which will tell us that there is magnesium toxicity is disappearance of the patellar reflex, that is the knee jerk. This is again important from MCQ, that if knee jerk is absent, almost the levels are 10 to 12 milliequivalents per liter of magnesium, and that we are close to the toxicity, so we should stop. We should withhold the next dose. It should be given only when the tendon reflex is present. Best marker is percentage SpO2, because that would, if that drops, if that falls, that will indicate that she is likely to have respiratory depression. It's a central depressant drug, so what, it will depress the respiratory center. So we are watching her respiratory rate as well. But the earliest sign before the respiratory goes down or SpO2 falls is absence of knee jerk. So please remember, again this slide is very important from MCQ. We have covered almost 5 MCQs in this. Zuspon and Sibai regime, loading dose is 4 to 6 gram IV over 15 to 20 minutes, and maintenance dose is 1 to 2 grams per hour infusion. What are the contraindications for MAGSELF? Myasthenia gravis, we are not supposed to give MgSO4, and impaired renal function. We have to have enough output if we are planning to give MgSO4. Cautious use of calcium channel blocker, as neuromuscular blocking action can be potentiated. Even when you give eclampsia, you take eclampsia patient for cesarean section, and if you have given magnesium sulfate, you should be telling this to the anesthetist, because this is how they can modify their anesthetic agents doses, because the actions they get potentiated. Neonatal effects of MgSO4, it causes lethargy and hypotonia only when there is severe hypermagnesiemia at delivery. Otherwise, fetus is not depressed at all with MgSO4. So that is why it is a preferred anticonvulsant. Now, what are the indications for termination in case of eclampsia or in preeclampsia cases? We usually, our aim is that fetus should achieve lung maturity and then the delivery should take place. So we want to take the pregnancy till 37 weeks. But if these things happen, then we should not bother about the fetus, then we should concentrate on the mother, because she is our first patient. Persistent hypertension more than 160/100 with antihypertensive. If it is persistently so high, it's not coming down even by 1 or addition of 2 or 3 antihypertensives, if it's not coming down, then we should terminate the pregnancy. Presence of eclampsia, terminate the pregnancy. Oliguria, worst indicator. If kidneys are getting affected, terminate the pregnancy. If there is thrombocytopenia, the count going down less than 50,000, we are not supposed to wait. Alteration in the coagulation profile or serum LDH level more than 1000 international units per liter, liver is failing, so we have to terminate the pregnancy. As I would like to repeat myself, that curative treatment for eclampsia, preeclampsia is termination of pregnancy. Till pregnancy is there, the disease progress will go on. That is why whenever these worst indicators are there, we should terminate the pregnancy. Fetal indications: fetus is mature at term, then don't wait. Termination. If there are decreased fetal movements, that also persistent, NST showing decelerations, terminate the pregnancy. Very severe IUGR, the baby is not growing, there is no interval growth seen, baby is not at all putting on weight, so there is no point in waiting. Or now the Doppler is the best mode to judge baby's condition in utero. So on Dopplers we are seeing the flows. If umbilical artery is showing absent end diastolic or reversed end diastolic flow, then that is an indicator of it indicates that the fetus is in acidosis and it's time to take out that fetus out of the womb. We cannot just wait on that fetus, otherwise it would land up in intrauterine death. So these all are indications for termination of pregnancy. Now we have seen the whole spectrum. We know the morbidities in mother, in fetus. So can we really prevent this? Again, MCQs. Yes, to some extent it is feasible, it is possible. Big trials are going on. How can we prevent PIH? The drugs used in prevention are like low dose aspirin. They balance those thromboxane and platelet aggravating factors. High doses of calcium, almost 2 grams per day, that will help in decreasing PIH. Antioxidants like vitamin C, vitamin E, lycopene, folic acid and other drugs like omega-3 fatty acids. So all these trials are going on. There are many more people are trying. So these drugs have some effect on decreasing the percentage of PIH. So again, remember few names like aspirin, calcium and antioxidants. So this finishes with the topic of PIH. Please remember or please concentrate on this because this is quite an important topic. Thank you. Thanks a lot.